ACL Dementia Grantee Developed Products from July 24, 2019, part of the National Alzheimer's and Dementia Resource Center webinar series sponsored by the Administration for Community Living.
Thank you so much, Steve. Welcome everyone to the webinar today on Administration for Community Living's Dementia Grantee Developed Products. In this webinar series, the Administration for Community Living's National Alzheimer's and Dementia Resource Center has partnered with the American Society on Aging. We're pleased to have all of you in attendance today. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi everyone, thanks so much for joining us today. I am super excited to have this webinar going to highlight the work of the programs that we at ACL have funded. And I just want to thank Jennifer Harvey and George Worthington for taking the time to share the outcomes of their projects with us. And with that, thank you very much everyone and our presenters, and back to you, Sari.
Thanks so much, Erin. George Worthington is the Dementia Services Coordinator with the Virginia Department for Aging and Rehabilitative Services, where he supports the Virginia Alzheimer's Disease and Related Disorders Commission, coordinates efforts to implement the Dementia State Plan, and is the co-lead of the Dementia Friendly Virginia Initiative. Jennifer Harvey is a social worker and certified dementia practitioner in New York's Capital Region, providing education to professional and family caregivers of persons living with dementia. We'll hear from both George and Jennifer today, and we'll start by sending the mic over to George for his presentation. Thank you both for being here.
Thank you, Erin and Sari. I am delighted to have this opportunity to share this project with you. The Collaborative Care Coordination Model was a key component of Virginia's Dementia Specialized Supportive Services project from 2015 to 2018. So this project was made possible through an Alzheimer's Disease Initiative Specialized Supportive Services grant from the Administration for Community Living, awarded to DARS in 2015. DARS worked with our great partners, the University of Virginia's Memory and Aging Care Clinic, which is dedicated to the diagnosis and treatment of people living with cognitive impairment and dementia, and the Jefferson Area Board for Aging, the area agency on aging serving Charlottesville and surrounding counties. So we did have some changes to project personnel over the course of the grant, but for the majority of the project, the grant was administered by Mary Margaret Cash and my predecessor, Devin Bowers, at DARS. Dr. Carol Manning and Dr. Scott Sperling of the Memory and Aging Care Clinic were the driving forces behind the project at UVA, with Dr. Manning in the role of principal investigator. At JABA, Marta Kane, the executive director, and Ginger Dillard, the director of advocacy services, were the key supports for this project. So before I started at DARS last year, I worked at JABA, initially as a dementia care manager on this project, and then as the manager of community resources, supervising the two dementia care managers. Without the great work of them, Liz Boyd and Sam Fields, as the dementia care managers, this project would not have been the success that it was. So I'd like to thank them for their great work on this project and their continued work supporting people living with dementia and their care partners. So this project was intended to serve as a pilot program for care coordination that would go towards fulfilling goal number 4 of Virginia's Dementia State Plan. That goal is to provide access to quality coordinated care for individuals with dementia in the most integrated setting. So that means a person-centered model with the people living with dementia as fully integrated into their community as possible. Coordinated care programs can help people remain at home for longer if that is their choice. So care coordination is a key component of the active management of dementia advocated by the Alzheimer's Association and others to help improve the quality of life of people living with dementia. Several of the components of active management are obvious, so I'll just highlight a couple of the others. The appropriate use of available treatment options would include recommending non-pharmacological approaches for behavioral symptoms to caregivers, or making sure that the caregiver understands the benefits, side effects, and indications of medication for depression or behavioral symptoms if the patient is taking them, or prescribing cholinesterase inhibitors depending on the stage of the disease. The effective management of coexisting conditions reflects the high prevalence of coexisting conditions among people living with dementia and the complications that can arise in clinical care from dementia by reducing the person's ability to manage a chronic condition or other health condition. An example would be ensuring continued effective treatment for diabetes or hypertension, although the person providing care may focus more on dealing with the symptoms of dementia. So while these first two require healthcare professionals to be involved, dementia care managers can be instrumental in driving the other 5 components of active management. So according to research by Borson and Chodosh, dementia care managers within health systems are the single most effective innovation for improving dementia care, as they can support people living with dementia and their care partners in those areas of active management, and specifically by helping people connect with and to educate them about available community resources. By coordinating care between community-based organizations and healthcare systems, and by delivering more intensive case management to improve outcomes. In our adaptation of care coordination, we focused on formalizing the second point by having the collaboration between the healthcare system and the Area Agency on Aging form the foundation of the program. So our adaptation looks like this. You have the healthcare system, specifically the memory clinic with its interdisciplinary team, including neurologists, neuropsychologists, nurse practitioners, and others, and the primary care provider in one pole, and the community-based organization as the other pole, with its services including companion care, home health, adult day programs, and more. But at the heart of the model are, of course, the person living with dementia and their care partner. But the DCM is right there with them and links them to the two poles. This model is currently being sustained with some changes, with the main one being that the links between the healthcare system and the community-based organization are no longer contractual. However, the dementia care managers remain tightly involved with the Area Agency on Aging in an informal structure. So the care coordination program enrolled people with a recent diagnosis of mild cognitive impairment or of a neurodegenerative disorder. In practice, people were often referred or introduced to the care coordination program as they received a diagnosis. We found that meeting the dementia care manager in person at the clinic was a much more effective way to introduce the program to prospective participants than to do it over the phone or by email. And this also enabled the DCMs to answer questions and provide some initial materials before the person had left the clinic. Participants also needed to be a resident of Virginia, but there was no specific catchment area. The program sought to enroll at least 200 individuals and care partners over the 3-year period, and to keep them enrolled through the grant period. So we took no new enrollments during the final year of the grant, reflecting the need to conduct evaluations at the 12-month point. And overall, we enrolled about 220 people into the program. The program itself provided a number of different services to the participants by the DCMs, including options counseling, so both DCMs were certified options counselors, eligibility assistance around programs such as SNAP, Medicaid, and others, education on dementia, and facilitating referrals to other community-based organizations for respite, home health, or sourcing medical equipment, among others. The DCMs also helped coordinate medical care, typically around their memory care, but when necessary, they also helped manage other health conditions. The overall goal of the program is to help persons living with dementia remain in their homes or the place of their choice for as long as they were able to safely be there. The DCMs were, of course, able to help facilitate placement in long-term care facilities as necessary. So the collaborative aspect of this model is really clearest around the DCMs. The grant project supported two, so one was hired by UVA and the other was hired by JABA, but through a joint interview process. The DCMs needed a background in mental health or social work, and both were housed within the Memory and Aging Care Clinic at UVA to easily connect with the participants and to allow maximum coordination with the person's healthcare team. While the model did see some changes over the project period, for the majority of the project, the two DCMs were supervised on a day-to-day basis by the Community Resources Manager at JABA, who also was responsible for the options counseling and information and referral programs. This helped to integrate the DCMs into the options counseling team at JABA in order to facilitate referrals and the sharing of resources and other information. Clinical supervision for the DCMs was provided by Dr. Manning and Dr. Sperling at the Memory and Aging Care Clinic in meetings held every other week. And of course, they were also available to the DCMs on an ad hoc basis. So we utilized existing training materials for the DCMs. They were trained in the areas shown on the slide. In the replication manual, which I'll give you a link to later on, it contains a complete list of the training materials used. Many of these were available on Virginia's allspossible.org website, and others came from the Alzheimer's Association and other sources. The services provided by the DCMs were informed by person-centered options counseling and the care coordination models to help individuals living with dementia and their care partners in various ways. And these included navigating the health system, providing information about dementia, exploring goals for care, and connecting them with the supports and services that would help them achieve those goals. So the program itself included the components that you can see on this slide. So I just want to stress that this is not a strict process, but it does give you an idea of the flow involved in the program. People were typically referred to the program on or shortly after receiving a diagnosis. The DCMs met with the individual and the primary care partner at the clinic to introduce the program. If the person decided to enroll, they were provided with a care coordination guide, which is a binder containing some basic information about their diagnosis, information about the Memory and Aging Care Clinic, including the names of all their care team, a list of topics and areas where the DCM could help, and a starting kit of resources, including the Alzheimer's Association and information for their local area agency on aging. The participants were also asked to review the list of topics ahead of the DCM's initial home visit, which was typically scheduled within 3 to 4 weeks. When the DCM called the family ahead of the visit to reconfirm, they could find out if the participants had specific areas they wanted more information about and prepare accordingly. At the initial home visit, the DCM completed baseline evaluations with participants and began developing the action plan through a conversational process. The DCM would follow up on any immediate steps and then check in at least monthly over the telephone with the participant and their care partner. There were follow-up home visits at the annual anniversary of enrollment to complete the follow-up evaluations. An important component was the DCMs attending clinic appointments with the participant and their care partner in order to provide another set of eyes and ears for the participant who might be finding the visit both physically and emotionally tiring. Throughout the program, the DCM would provide emotional support to both the person living with dementia and the care partner, as well as giving referrals and facilitating connections with supports and services as needed. Finally, the DCM was able to help with transitions between home and other care settings. So here you can see the key outcomes for the participants living with dementia and for their care partners. So the DCMs administered several measures at the initial home visit and then at the 12-month intervals. For participants, the people living with dementia, at baseline, 79% screened positive for depression, while at 12 months that fell to just 11%. Care partners saw a decline from 77% at baseline to 16% at the 12-month point, and then just 12% at the 24-month point. Both persons living with dementia and their care partners saw a trend towards improved quality of life from baseline to 12-month follow-up, but the changes weren't statistically significant. Care partners noted a decline in the severity of their reaction to behavioral symptoms and a decline in the number of those symptoms, suggesting an improvement in self-efficacy over the course of the program. Importantly, care partners reported a reduction in burden and an increase in their ability to look after themselves. Individuals reported the program helped them to prepare for the future and adjust to the diagnosis. And care partners reported similar results, as well as greater access to and knowledge of community resources. Both persons living with dementia and their care partners reported reductions in stress. So, like any new program, we did face some challenges over the years. The first was integrating a team across two distinct organizations. So the project as set up included quarterly phone calls for the key players in all three partners, But with hindsight, we felt that in-person meetings might have facilitated the relationships better than telephone calls. Also, having one DCM working for each organization was great in theory, but it was actually pretty difficult in practice due to differences such as benefits and working experiences. So much closer consultation between the three partner agencies over the DCM role helped iron out these problems in years 2 and 3 of the grant project. The second challenge was staff turnover and the continuity issues that raised for participants. When the 2 initial DCMs left that role near the end of year 1, participants inevitably felt a bit of disruption. However, we had a solid continuity plan in place and the participants clearly perceived value in the program. So only 4 of just over 100 participants at that point withdrew during the period. In addition, my predecessor here at DARS left the agency with just a few months to go in the grant period, so there's a little bit of discontinuity in terms of the links among the partners at the end, but that didn't affect the participants. Third, the average complexity of casework increased significantly over the project period, reflecting disease progression among the participants and the resulting changes in their needs. So there were changes in the demands on the DCM's time as a result. And finally, sustainability is often a challenge. So although we weren't able to secure funding to maintain this exact model of care coordination, the 2 dementia care managers from this program continue to work in the Memory and Aging Care Clinic, providing care coordination services to families living with dementia. The end of this project also led to the end of the formal links between the clinic and JABA, but robust informal links have been maintained, such as including the DCMs in JABA's monthly options counseling meetings and continued quarterly meetings with the DCMs, a representative from JABA, and the local chapter of the Alzheimer's Association. This approach has meant that the strong links and benefits created through the collaborative care coordination model have been maintained. And these are some of the key lessons learned by DARS and the partners from this project. So most important was the value of the home visits. These ended up being one of the most valuable components of the program. And initially, we had planned to conduct home visits only for people living within 80 miles or so of UVA. But we quickly realized that the insights gained by the team and also the opportunity to build rapport afforded by visiting people at their home was well worth the sometimes lengthy drives. Also, we had initially proposed splitting the caseload by service area, with the JABA DCM covering its service area of Charlottesville and surrounding counties, and the UVA DCM covering other areas. But this did not prove to work in practice, since UVA's DCM would have been landed with the majority of the travel for home visits. So instead, we grouped enrolled persons into several geographical areas, and then all cases in that area, in a particular area, were assigned to one DCM. And both DCMs carried cases in the local area. The second lesson was about realistic caseloads. So we had initially proposed caseloads of 100 participants and care partners or dyads per dementia care manager, but that was felt to be overly ambitious given the intensive nature of the work and also the demands of other components of the overall AEI-SSS project. So we settled on aiming for caseloads of around 50 dyads per DCM. For any replication of this model without the demands of the other project components, a full-time DCM should be able to handle somewhere around 60 to 75 dyads. But there is a need to balance this, of course, with the increasing complexity that comes over time due to the disease progression. The third lesson is about creating realistic expectations. So I guess reflecting the level of trust that families placed in the DCM, they sometimes expected a lot more from them than they could provide. So for example, some people continued to turn to their dementia care manager for help and advice even when the individual living with dementia had transitioned into a long-term care facility and was no longer formally involved in the program. And lastly, the importance of unified supervision. So at the beginning of the program, both DCMs left after the first year, and one of the areas identified for improvement was the need for consistent and similar working experience, including regular one-on-one supervision. When 2 new DCMs were hired, they ended up reporting on a day-to-day basis to the Community Resources Manager at JABA, and this unified structure helped overcome some of the hurdles that I mentioned earlier. And happy slides. So our team was honored to receive 2 awards from the Collaborative Care for the Collaborative Care Coordination Program. We won a Best Practice Award from Virginia's Commonwealth Council on Aging, and also an Innovations Award for Health LTSS Integration from N4A. And the picture here is from the first award, and it shows our core team. So from left to right, we have UVA's Dr. Scott Sperling, the 2 dementia care managers, Liz Boyd and Sam Fields, JABA CEO Marta Kane, and Memory Aging Care Clinic Director Dr. Carol Manning, and that's me holding the award on the right. So the resources to replicate this project are available to download from the Virginia Department of Aging and Rehabilitative Services website on the link shown here. The Collaborative Care Coordination Manual includes samples of the Care Coordination Guide provided to participants, a job description for the DCM, a list of the training materials, and also outcome measures, and a sample budget. And finally, here are my contact details and the DARS Dementia Services website, and also Virginia's All Possible website, where you can find information about some of our other programs that have received ACL support. And with that, I'll turn it over to Jennifer. Thank you.
Thanks, George, and hello to everyone who's tuning in. Again, my name is Jennifer Harvey. I am a social worker at Eddy Alzheimer Services in Cohoes, New York. There we are. And today I'm going to be talking about our dementia training for people with intellectual and developmental disabilities. This project was supported in part by a grant from the U.S. Administration for Community Living, ACL, and we're so appreciative of their support and guidance throughout this process. We're still actively working on this project, rounding out our 2nd year within the next month. So the objectives that I hope to meet during our time together today is to describe the importance of quality dementia training for professional caregivers of people with intellectual and developmental disabilities. I'm going to do that through sharing about our project and discussing our progress, including lessons learned, challenges, and continued plans for implementation. I also want to identify for you some readily available tools and resources that can be used in your practice setting. So I want to start by giving a bit of context to our project by describing our agency. Eddy Alzheimer Services is a community-based agency located in the Capital Region of New York State. We are part of a larger health system, St. Peter's Health Partners. We're primarily funded by a grant initiative through the New York State Department of Health aimed at supporting family caregivers of people living with Alzheimer's disease and related dementias. We provide a variety of educational opportunities, support groups, ongoing case management, and we have a robust respite program to caregivers in a 10-county region. Through the receipt of our grant from the ACL, we were able to expand our services to support those living alone with dementia, as well as taking on several other projects, including the curriculum I'm going to speak about today. So there's an increasing need for dementia training in agencies that serve the IDD population. And while many agencies do have an aging committee and sometimes aging-related trainings, they're not all talking about dementia specifically. With better supports, healthcare, and understanding of intellectual and developmental disabilities, individuals with IDD are living longer and better than ever before. Individuals with Down syndrome are also at a significantly higher risk of developing Alzheimer's disease. This is because one of the primary risk genes for Alzheimer's disease is found on chromosome 21, and as many of you know, people with Down syndrome have a third of the chromosome 21. People with Down syndrome also age about 2 to 3 decades faster or earlier, I always say whichever term makes more sense to you, than the general population. So we do see Alzheimer's disease or other dementias earlier in their lives. The agencies that we work with have missions that promote independence, personal growth, and community integration for those they serve. And as these individuals' needs change throughout the aging process, it's important for staff to also feel supported and validated that they're still providing appropriate quality supports and services to their clients. Dementia, as we know, brings a specific set of challenges and requires training that takes into account the skills that these providers already have and how they can use them to enhance and improve quality of life. So we created the Foundations of Dementia Care training to be delivered to direct service providers, administration, behavioral specialists, social workers, nurses, and psychologists employed by the agencies that we would partner with. We wanted the training to be accessible to anyone who wanted to attend. We decided that we would provide the training as a single 3-hour course that would be offered on-site for each agency multiple times throughout the year. Each agency was responsible for recruiting and registering their own staff through whatever internal system they employed. The tool used as a pre- and post-assessment is the IDD and Dementia Knowledge Scale from the Center on Intellectual Disabilities at the University at Albany. So the training is broken into 4 parts: an overview of dementia and the specific conditions and diseases that cause dementia, a discussion of the brain, including parts of the brain and what each part does, the impact of dementia on the brain, and strategies to use based on these cognitive changes. We also do a role-play exercise and a discussion of behavior and practical approaches. We begin with an overview of dementia, and these are just screenshots of a few of the slides that are part of the training. For some attending the training, the concept of dementia is completely new for them. So it's really important that we include this in our training. For many others, it's not an area where they have much practical experience necessarily. So we discuss some of the common conditions and diseases that cause dementia, the importance of early detection and diagnosis, and the ways that different forms of dementia can impact their clients. We then move on to a discussion of the parts of the brain. We discuss what each part of the brain does and how dementia can impact those abilities as it progresses. This hands-on activity involves participants coloring a diagram of the brain, which also engages their brain in a very different way, and we find that this is really effective even for adult learners. As we discuss these changes, we talk about specific strategies to use when working with a person with dementia. We talk a lot about baseline and how important it is to know the baseline of each of their clients, and we also relate these dementia-specific strategies to the skills and knowledge that the participants already possess through their work with the IDD population. I always tell those who I'm training that it's very nice to be talking to folks who are already so familiar with having to modify their strategies and modify their own behavior to be able to be most helpful to the people they serve. We move right from this module into interactive role plays. These are completely scripted and ask participants to just be themselves, staff supporting a person with IDD and dementia symptoms. So the trainer plays the person with dementia. We play out each of the 5 scenarios twice. The first time is the, as I call it, not so good way of handling the situation, and the second time we see some of the strategies played out. We then have an often lively discussion of what was better the second time around. It's a great opportunity for folks to ask questions about the skills they're seeing, and we often have a few laughs. We always get lots of nods from those watching. Yes, I've experienced that, which is so validating for the staff. Lastly, we discuss behaviors. IDD workers are very able to relate to the concept of labeling people by their behaviors. So they're often very open to the idea of thinking of behaviors as behavioral symptoms and a form of communication for folks with dementia. They're also often familiar with the ABC model and appreciate the use of this in dementia care. We end our discussion of behaviors and the training by talking about a variety of tasks and situations where there may be an increase in behavioral symptoms from the person with dementia. Here you see an example of meal times. We also talk about bathing, dressing, wandering, hallucinations and delusions, etc. And as you can see, this part of the training is very practical. We look at what the staff person themselves can do and also discuss environmental modifications for each topic. So I want to talk now about the training development. This training was developed over the course of several months before being implemented in its final version. I had the pleasure of working with Dr. Phil McCallion, who is an expert in IDD and dementia, who's also a part-time local to the Capital District here in New York. One of the resources he shared was a training program he helped to develop with the Minnesota Department of Human Services entitled Serving People with IDD and Dementia, Online Training for Case Managers, Assessors, and Providers. This training is free to the public and can be accessed using the link in the slide, as well as through the Minnesota Department of Human Services website. The videos embedded in the training have been an excellent supplement, and a few of them are used throughout our Foundations training. We were also given the opportunity to attend a workshop and train the trainer given by the National Task Group on Intellectual Disabilities and Dementia Practices, otherwise called NTG. This training is entitled Dementia-Capable Care of Adults with Intellectual Disabilities and Dementia. Not only is the NTG website fantastic and full of many resources, they also offer trainings and webinars throughout the year, so I encourage you to look at their website and check them out as well. Their NTG Early Detection Screen for Dementia is also available through a link on this slide and through their website. The agencies we work with have begun to use this tool, and your agency can use it as well. Again, we spent several months drafting training materials and soliciting feedback from the two agencies that we partnered with to pilot this program. We first did a trial training with administrative staff from each agency, and this resulted in important changes to the structure of the training, including the addition of the brain activity and important edits to the role play exercise. It was very important to tap into the transferable skills that IDD support staff and professionals already possess while structuring this training, so talking to the administrative staff before that was really helpful. When it came to implementation of the Foundations of Dementia Care curriculum, Eddy Alzheimer Services developed relationships with two local agencies who support individuals with IDD, the Center for Disability Services, which I'll from now on call CFDS, and Wildwood programs. Both CFDS and Wildwood have residences, day programs, schools, and family support programs with a large service area, and both agencies identified dementia as a current and increasingly important issue that they needed help to address. We started with monthly trainings at each site and then began alternating agencies each month over the course of the last year. Trainings could be offered at various sites within the agencies. For example, Wildwood held some of their trainings at residences, making it easier for residential staff to attend as a team. We also offered other training opportunities to agency staff at our site, including our Eddy Alzheimer Services caregiver chats and topics in dementia care. These are one-hour seminars offered monthly at Eddy Alzheimer Services geared toward family and professional caregivers on a variety of topics. As we began getting requests for family caregivers to attend the Foundations training, which we didn't feel was quite the right training for them, we decided it was best to offer a separate training and event for family caregivers. So we created a 2-hour seminar specifically designed for family members of persons with IDD and dementia. It also includes a dementia overview, but we talk a lot about the emotional component of dementia caregiving, practical strategies, and lots of time for discussion and questions. These caregiver events have been offered at both CFDS and Wildwood at their request, and they're internally marketed by each agency. The Foundations of Dementia Care training has been provided to just over 260 staff across both agencies, as well as one training at a third agency that we're hoping to foster a relationship with over the coming year. We have hosted 3 family caregiver events with approximately 20 attendees total. Some of these caregivers have gone on to complete a care consultation at our agency and receive other services from Eddy Alzheimer Services, including respite and support groups, so we're really excited about that. We collect pre- and post-assessment data at each of the Foundations trainings. The IDD and Dementia Knowledge Scale, which I mentioned earlier, consists of 20 true-false questions, which we were approved to shorten to 16 questions for our purposes. So some of our outcomes so far are that 63% of staff who completed both the pre- and post-assessments demonstrated an increase in knowledge. We would like to see these numbers improve and believe there might be a few factors that impact these scores. Many participants note confusion around the wording and the specificity of some of the items on the assessment. The training also has a large focus on strategies and practical application of skills, while the assessment is knowledge-based. And while the knowledge is incorporated into the training, we're not sure that it's sticking, so to speak, as well as some of the other more practical and hands-on information being provided. We found that 25% of folks taking the pre- and post-assessment maintained their score from pre to post. Another challenge that we faced is that we don't always collect a pre- and post-assessment from everyone who attends. 28% actually of those who attended a training did not complete one of the assessments. We have people arrive late, leave early, or simply, unfortunately, choose not to complete the assessment at times. We're working with adult learners who have their own schedules and commitments that sometimes preclude them from finishing one assessment or another. Some of the changes we have considered implementing to improve participation are incentives for staying and completing the assessment, asking attendees to complete the pre-assessment before they come to the training, although we're not sure how we would do this logistically, and or completing the assessment in a read-aloud format done by the facilitator so that everyone in attendance is completing it together. We've also discussed asking people to get to the training 15 minutes early to get it done, but a 3-hour commitment has already been difficult for some to accommodate in their schedules. So we're not sure exactly how that's going to work out, but we would like to see that improvement as we continue on. So we've had several successes as we've worked on this project. We were really lucky, really for lack of a better phrase, that we got early buy-in from administrative and clinical staff at both agencies. They really seemed to understand the importance of this training, and they were happy to benefit from the project. One of the reasons for this, I believe, is that dementia is such a universal topic. So many of our initial contacts, each of these agencies get it because they have either a personal experience or maybe an experience professionally with dementia. With administrative and clinical staff on board, it was their encouragement to managers and direct service providers to get staff trained, and that's what really made things happen. Another success is that Eddy Alzheimer Services has the ability to provide additional services to staff and family caregivers. This made us more relevant and more successful in reaching staff. We've had staff from both agencies actually contact us about a personal matter regarding a loved one with dementia after attending the training, and we consider this a great secondary success. The format of the training has also been a success. Staff report that they like how interactive it is, especially because it is 3 hours long. We all know that feeling of not knowing what to expect from a 3-hour training. It can either fly by or drag. So they've really reported that they like how interactive it is. The brain activity and interactive role plays are helpful in breaking it up and keeping it engaging. Attendees have also reported how accessible the material is to all staff. Professional and administrative staff report learning just as much as DSPs. They don't feel like it's too beneath them, for lack of a better phrase, and nor do the DSPs feel like it's too not accessible for them. We've done a great job of identifying key players and maintaining a core team at each agency. And I think a lot of that just has to do with consistent communication. So these core teams were different at each agency. For example, at CFDS, we have a staff development person, but not at Wildwood. It's a team of 2 nurses, a psychologist. So it's really different at each agency, but we found that it works as long as we consistently communicate with them and keep them engaged. We have also offered opportunities for these key players to participate in additional training. The NTG training I described earlier was paid for by EAS for both agencies to send staff to. We've also really made an effort to accommodate their training schedules, been flexible with locations, and offered perks like bringing light refreshments to trainings. And those sound simple, but they're really great ways to keep people engaged and happy to work with us. So challenges and lessons learned. Of course, with any project like this, we expect to see some challenges arise. One was the length of the training. 3 hours is too long and not enough time all at the same time, which I'm hoping people can relate to. We did have to advocate for a 3-hour training initially because administration from both agencies were not sure that they could get staff to attend for that long. They're used to 1 to 2 hour trainings. So now that we have the 3-hour training, we find that it has been well received, but we could always use more time. This also begs the question, is one training enough? It's been a challenge for me and our agency to feel like we're providing enough training and information. As many of you can relate, it never really feels like you can have too much dementia education. Another challenge has been reaching other agencies who serve the IDD population. It was just recently that we were able to get into a local ARC to do a training for them. And we believe that some of the reasons for this might be questions like, do they identify dementia as a pressing issue for their agency and their clients? Are they willing to make this training mandatory for staff? And if they don't, will staff attend? And as an outsider to their agency, they might ask themselves, what does the Eddy have to offer? And why should we care about what they have? This poses challenges for us because really until they see the training, they might not realize its value. We do have a training outline which we've been able to send to agencies so they can get some sense of what to expect, but it's really difficult, again, to get them to picture what the training is going to be. A lesson learned for our agency has been to better outline expectations between Eddy Alzheimer Services and the agencies that we work with, Wildwood and the Center. Having a memorandum of understanding from the start of our relationship with each agency we find would have been helpful. And lastly, we struggle with the unknown factors of providing a training like this. There isn't really a measurable way for us to track sustainability and practical applications of the skills once folks take the training and go back to where they're working. So this might be something we could explore in more detail if we had the opportunity to do it again. We're excited for our next steps and the things that we are doing to try to encourage sustainability. Actually, tomorrow we're holding a Train the Trainer for staff of both agencies who have attended the Foundation's training to be trained in providing the curriculum at their agencies. This allows them to continue to teach us important information in-house, and we have 26 people registered to become trainers. With more of them than just me, we hope that they'll be even more able to accommodate the needs of their staff. We have begun providing behavioral consultations for residential and support staff around the specific needs of an individual client with dementia, and this will be a focus of our work with the agencies in the coming year now that we have this relationship with them. We're continuing to offer family support and programming at each of the agencies, and we'll be spending some time working with them to find out how this can best be accomplished over the course of our final year. We also continue to take steps to connect with other agencies who might benefit from this training. As I mentioned, we were successful in connecting with a local ARC and providing a training to them last month. And with Center for Disability Services and Wildwood providing their own trainings, this will allow more time for us to work on this even more. We also hope to provide another Train the Trainer opportunity in the new year. We've certainly learned a lot. We hope that our experiences and the resources shared can help you as you incorporate dementia training into your agency. And I thank you for taking the time to learn about our project today.
Great. Thank you so much, George and Jen. That great presentations. We have a lot of questions that have come in so far, and we'll encourage people to continue entering questions into the chat feature of the webinar platform. We have some time to address those questions now. So, George, I'm going to start with you. A few questions came in while you were speaking and afterwards. Can you talk a little bit about the specific tools that you use to measure your outcomes for the care coordination project?
Sure. Going back to the slide I had, starting with depression, so we saw reduced depression. We measured that using the Center for Epidemiologic Studies Depression Scale revised, so the CESDR, which is a 20-item measure for depression. For quality of life, we use the Quality of Life in Alzheimer's Disease, QOL-AB. And I believe all these measures are available on the NADRC website, or at least links to them. For behavioral symptoms, we used the Neuropsychiatric Inventory short form, the NPIQ, and the Revised Memory and Behavior Problems Checklist, the RMBPC. The other measures that I talked about were measured using a survey, a satisfaction survey that we created for the project.
Great, thank you. And you are correct, on the nadrc.acl.gov website, there is an instruments guide that talks about various tools that can be used to measure an array of different items such as depression, quality of life, self-efficacy, etc. And if you are interested, you can visit the website to find that document, and I will try and post the link while we're still on this call. Jen, we had a question come in for you. Someone wrote in saying that they have a similar training related to dementia and intellectual and developmental disabilities, and they have partnered with some community organizations that serve people with intellectual and developmental disabilities. And they were trying to promote a training for family members, but had trouble recruiting people to attend. So they were looking to you to get some tips on how you were able to recruit family members, what techniques did you use, and how many family members have you been able to train so far?
Great question. We've done 3 family caregiver events, trainings, and as I said, we've only had 20 folks to attend those across those 3. So it definitely is challenging to recruit people. The recruitment happens really by the agencies themselves, not necessarily by us, because they're the ones who are in contact with those people, and they really find the best way to recruit is by personal invitation. Inviting people who they know are impacted by this. But they've also cited that one of the challenges to that is that they may identify this person as being related to someone with dementia, and that person may not, as we all can relate to, may not identify that or be ready to talk about that. So I wish I had a better answer. But they have found that the best way is to really have that personal invitation and have that conversation with the family caregiver. A lot of times it's one of the social workers addressing them, or a nurse, or whoever is sort of that trusted person to say, this is going on, and you really should come to this to learn more. So again, I wish I had a better answer to say, this is how you get a lot of people there, but we're just happy that when we get a few people there, and that feels successful to us, so good luck. I think the personal invite is the best advice I can give.
Great, thank you so much. We have another question for you, George. A few people asked to get a little bit more information about the DCM. They were asking how the DCM integrated with any existing service coordination staff, and then the follow-up, for those who may not have grant funding, do you think DCMs would be able to be volunteers or AAA staff?
2 great questions. So in terms of the DCMs interacting with existing service coordination staff, so within the Memory and Aging Care Clinic at UVA, there was a nurse coordinator and also a social worker who were part of that interdisciplinary team. So they would be working with people who weren't in the care coordination program, and the DCMs could take advantage of their knowledge of services, as well as connecting with folks at JAVA, the Area Agency on Aging that they were linked with, to expand their own knowledge and share that with the families they were working with. So they worked closely with both the nurse coordinator and the social worker. The nurse coordinator would also be involved to some degree with the general clinic visits and things with the person living with dementia and the care partner. We worked it out so that the DCMs would share some of the responsibilities. So, for example, if a care coordination participant were coming into clinic, the DCMs would do the final wrap-up of the visit with the individual living with dementia and the care partner, instead of the nurse coordinators. So they kind of shared those responsibilities for the people in the program. And then the other question about having volunteers, is that what the question was? Having volunteers, and could
volunteers, could volunteers or AAA staff serve as DCMs, in your opinion and your experience?
And also funding. In terms of, so in terms of funding, so different areas are pursuing different models of funding. You might look for other grant opportunities. Some states are funding programs like this through general funding. There's also the Medicare code for care coordination or care planning services, and those services can be provided by, according to Medicare, appropriately trained members of the clinical team working with the eligible providers. So you could have care coordinators working under that Medicare code to some degree. And as far as volunteers go, I think there's lots of great ways that volunteers can help support people living with dementia and their care partners. But I think it would raise some issues to have volunteers in these positions simply because of the depth of knowledge required, and it is quite intensive and intensive work, and keeping the volunteers engaged in something with such a high pressure might be difficult. And there might be some issues with confidentiality and HIPAA as well that would be better addressed through staff. But there's certainly no reason why Area Agency on Aging staff couldn't provide this type of service. In fact, there are models in different parts of the country where AAA staff are providing exactly these kinds of services.
Great, thank you so much. Jennifer, the next question is for you. The person who asked the question is wondering if the community organizations you were partnering with paid their staff to attend the training, and what time of day seemed the most effective to schedule the training, or did it vary depending on where you were?
Okay, great question. Yes, all of the staff. This was part of their normal work day, so they were paid to attend the training at both agencies. And in terms of time of day, we actually tried a few different times, and both agencies have now settled on 10 to 1 or 10:30 to 1:30. I don't really know exactly how we came to that, but we did try like 9 to noon, 1 to 4, and both sort of evolved into wanting to do it from 10 to 1, or again 10:30 to 1:30. So that seems to be a good time for them. A lot of it had to do with just shifts, getting people, when they're sending residential staff, it's getting their folks out to wherever they're going to be for the day, so they need time to do that in the morning. So we found that's why mornings weren't great for them, and kind of same with the afternoons, having to be back home by the time their folks came home from wherever they were all day. So I think that's sort of where the middle of the day came into play, and that's worked out well, and that's now been the time that they've just stuck with.
Great, thank you so much. There's a question that came in for both of you. In your project, did you use a telehealth virtual approach at all, or have you considered that? So George, do you want to start, and then Jen, you can chime in?
Sure. So we did not use a telehealth approach with this particular program, apart from obviously the monthly telephone calls to the participants or the care partners. But we have used telehealth in other projects that have targeted care, providing counseling for care partners via telehealth, and that's been very successful. And there's no reason why you couldn't do this through a telehealth approach. We just that wasn't part of our program.
And,
great, thank you. Jen, any comments?
Yeah, we also have not used that approach. We definitely have considered it and talked about it a little bit, but we have not at this time. You know, I would love to have online modules of trainings for folks, and we did talk about maybe breaking things into modules that they could watch at their own convenience, but then there's a certain element of being in person, and especially with the more interactive things that we have going on in the training, there's a real benefit to that too. So that's why we haven't really gone too much further in exploring that. But it's a great idea. I love making it accessible to whoever needs it.
Great, thank you so much. So George, another question came in for you regarding outcomes. Besides decreased depression, were there any other statistically significant findings?
Yes. So on the outcome measures slide that I had, all of those were statistically significant except the quality of life. That we only saw a trend there. And then we did use some other measures as well that we did not get statistically significant results on, such as healthcare utilization. And then the results from the satisfaction survey were in terms of percentages. So, for example, the reduced stress, we saw somewhere, about 85% of participants said they saw reduced stress after 2 years of the program. For care partners, the number was 80%. So, I mean, those were self-report and not a validated measure, but just the survey.
Okay, great. Thank you. So we are coming to the end of our time together. I wanted to point out I did send out the link for the National Alzheimer's and Dementia Resource Center Dementia Instruments Guide. So that was sent out through the question and answer chat feature. So I hope you found that. If you have any further questions, you can see the contact information for both of our speakers on the slide in front of you. And we want to thank you so much for joining us today, and a very special thanks to both of our presenters, George Worthington and Jennifer Harvey, for spending time with us today to tell us about their excellent programs to assist people with dementia and their caregivers. So with that, I'll turn it over to Steve Moore for some final comments.
Great. Thank you, everyone. Yes, it is time for us to wrap up today's presentation. We do thank you for joining us.